Now, the South African government is taking a big step towards plugging the gap that has been left by the unprecedented United States withdrawal of support for the country's HIV/AIDS programs. Earlier this week, Health Minister Aaron Motsoaledi announced a 1 billion rand funding injection to mitigate the damage. The minister has further announced an allocation of 750 million rand to the department for its HIV and AIDS programs. The question is this enough? To help us answer this question, I'm now joined by Russell Rensburg, a director of the Rural Health Advocacy Group. Mr. Rensburg, thank you so much for your time and for joining us this evening. So it's been about 5 months since that withdrawal of about 7 billion rands that had been allocated towards HIV and AIDS funding. The minister has now responded with that injection that will go in. Do you think this is enough?
It's literally a tenth of what we lost, but look, I think it's a step in the right direction.
Most certainly. And how do you then think we need to find ways in ensuring that with the step in the right direction, the country is able to get more funding that would be able to assist in that shortfall?
Look, I think what we need to really start looking is what is the instruments that we have, what are the things that work, and how can we make them work better? So one of the things that have been very successful in the response to HIV in South Africa has been in the introduction of the HIV/AIDS conditional grant, currently called the District Health Program Grant. Now, conditional grants are measures that allow for the implementation of national priorities and allows for them to be coordinated from a national level along with the provinces. As you know, our country health is a concurrent responsibility where both national and provincial departments have legislative authority. And what this has meant in recent times has really been more of a fragmentation, as each of the provinces often act independently and autonomously. Now, by using the District Health Program Grant, which has a component for HIV, has a component for district health services, and as well, if well amended, we could actually allow for integrating into the health system some of the NGOs previously funded by PEPFAR to do the important work of coordinating the response. And I think over the next 3 years, we should use these mechanisms to lay the foundation for an integrated response rather than parallel responses. So we don't ever get into a situation where we are today, where we can, in essence, not bring in that 15,000 healthcare workers that were funded by PEPFAR, of them 2,000 nurses, 300 doctors, over 8,000 community workers, including data captures. And I think as we move forward, we must be careful not to try and integrate those people too early, right? Because I think our system needs the management strengthening at the district level to make sure that the investments we make really deliver the result we want.
And any shortfalls that you might foresee with the district health program? I mean, you do mention that this is an existing instrument. How do you think we could already circumvent some of the shortfalls that we could foresee in the near future?
Look, I think first thing is prioritization. You know, one of the areas that is very important to us is obviously the HIV program has delivered a lot. You know, the rapid rollout, at least in the last 10 years, of ARVs have resulted in increased life expectancy, reduced maternal mortality, increased neonatal survival, increased under 5 survival, and so much more. But all those gains are at risk if we don't really coordinate our response in such a manner that we do the things that are both urgent and important rather than trying to do everything. And one of those areas is tuberculosis. Tuberculosis is the leading comorbidity for people living with HIV and also the leading cause of death. Unfortunately, the minister's initial response wasn't abundantly clear on the extent to which that additional funds that are putting into the district health program grant as to whether it will fill the gap for the 600 million or so gap we have in TB testing. So one of the things that we strongly advocate for is increased testing for TB. By increasing and accelerating testing, we can find TB. And when we can find TB, we can cure TB. And if we cure TB, we reduce the deaths close to 56,000 each year. And half of those are mostly people living with HIV. So I think that's an area where we need to really just invest in heavily. Linked to that, we also have what they have, the 1.1 campaign, which is a well-considered campaign. The goal there is to really re-enroll and enroll new cases of people living with HIV who know their status and are not in treatment, right? And mostly men, over 600,000. If we can successfully re-engage those people into treatment, we can increase life expectancy, and we can reduce the risks associated with late-stage HIV, which unfortunately still contributes to a number of deaths. So I think the two programs we have from a national level needs to be scaled down to a provincial level, and there needs to be greater coordination between national and provincial on doing the things that are urgent while looking at how we can find the funding for things that are important.
We've seen recently some advocacy groups have been having the question around resources, especially when it comes to healthcare in relation to illegal foreigners in South Africa. And many of them are saying South Africans need to be prioritized when it comes to the distribution, especially of medical care and medicines within our borders. What impact does the overcrowding and the porous borders have, especially now at a time when we've got this funding that has been withdrawn? Like you mentioned earlier on, only 1/10 of it is now being made available. And now with over the populace of an overcrowded health system, what impact does this then have on the rest of the country?
South Africa, has really, through our constitution, we obviously guarantee everybody the right to healthcare services. And from the earliest days of the response to HIV, we've always considered this a response of immense public health importance, right? Because diseases don't know nationalities, and they move over and they can impact everybody. So everybody has access to free primary healthcare services in South Africa. And I think it's an important consideration that we should continue. Because there are undocumented migrants living in our country. There are migrants that have been here for many generations or for a long period of time. They live amongst us. They are South Africans or live here, and they pose, and they're entitled to the healthcare services available in the country. We have to manage our services better. We have to look for the efficiencies where they are. And I don't really think that 5% or so, which is being attributed to foreign nationals, completely shape the health system. But what we do need to do is really make use of the money that we have effectively by ensuring that we have quality care at the right level, more people accessing healthcare, primary healthcare rather than at hospitals is much more efficient. And I think when everybody comes together and we set a certain set of priorities, these things shouldn't stand in the way of us delivering quality primary healthcare. Right? So I don't think a matter of nationality or whether that is contributing to. We haven't seen clear evidence that is actually contributing to overburdened services. Rather, we haven't funded the healthcare system effectively since at least 2012.
Right, Mr. Rensburg, unfortunately, we have run out of time. I really would have wanted us to stretch a little bit on that issue. But thank you for giving us your time this evening. That was Russell Rensburg, the Director of Rural Health Advocacy Project.